Mm.
Hello, everyone, and welcome to our PACE webinar. My name is Hannah Tebeka Azriel, and I am very happy to welcome all of you to this webinar. First of all, I'm so happy to welcome Dr. Tristan Mehta. Welcome, and thank you for being with us tonight.
Thanks for having me, Hannah. Pleasure to be here.
Maybe we can share our slides already, actually, Dr. Mehta.
Of course.
And I would like to just give you a little overview of how things will go tonight. It's a 1 hour webinar. We will have a presentation, and please don't hesitate to ask all of your questions in the Q&A or in the chat. Just know that we will answer all of the questions at the end of the webinar. Also, this webinar is being recorded. So if you're missing any part, don't worry, you will receive an email tomorrow with the replay available. Maybe switch to the next slides. I will introduce Dr. Tristan Mehta, who is the founder and CEO of Harley Academy, which is the largest postgraduate training provider in aesthetic medicine in the UK. He has over a decade of experience in medical aesthetics and education. Dr. Mehta holds a postgraduate diploma in skin aging and aesthetic medicine, and he is recognized for his strategic vision, educational leadership, and commitment to industry standards. So thank you so much for being with us again. And I guess we can already start the webinar. I'm giving you the floor already.
Perfect. Thanks so much, Hannah. I'm just going to message you briefly. Okay, so guys, thank you so much for joining me this evening. As Hannah introduced, my name's Tristan. I've been working in aesthetics for 10 years, and I'm going to share with you my insights into how to inject, but using minimal amounts of volume for maximal impact. And this is a two-way conversation, okay? So I've got my presentation. It's going to take about maybe 45 minutes. If you want to put something in the Q&A or the chat, then please make sure to do so. And then I can see what we're saying as I go along. You can also interrupt me, put your hand up, tell me what you have as questions, and we'll go from there. So I'm just going to check, Hannah, have you enabled the chat for everyone?
Oh,
Um,
that's it should be enabled. Wait.
there's a little the setting you can change.
Yeah. Oh, yeah. Okay. I'll do it. I'll do it right now.
All right. So, guys, let's get started. Briefly, this is Harley Academy London. Hopefully, some of you on this webinar this evening would have trained with us over the last few years. This is our flagship academy, and this is a little snapshot of some of our faculty. We're a team of over 80 educators and clinic staff and office team based in London. And we really, for me, I just want to tell you a personal story, which is that from the very beginning, I didn't resonate with the industry or the field. I didn't see how it was possible that people were learning how to do injectables over a weekend. And so I've spent the last, 10 years of my life thinking about higher education. That means people pursuing a degree or a qualification or a diploma in injectables. And so that's really what we are doing. And that's why I would say that we're more of an education brand rather than a training company. And a lot of the educational insights that I'm sharing with you this evening are based on some of the fundamental philosophies that we have at Harley Academy, some of the principles we have for injecting, all of that. I'm hoping to share with you basically three very important uh, ideas for how to start injecting in a really modern way. And you may be familiar with how injections were done 10 years ago, which was people were very excited to share that they were injecting patients with 20 mils of filler. And it became a little bit of a badge of honor, a little bit of a pride in the fact that they had patients that were willing to spend, 3,000, 4,000 euros, pounds to have these full face treatments, almost to say how experienced injectors were, or how intelligent or how smart they were. And uh, I also think a lot of this has been driven by the pharmaceutical companies who naturally have a very good incentive to want you to inject as much volume as possible. So what has changed really since then? Well, first of all, um, the scientific basis upon which we inject has changed. And one of the most striking things that has become apparent to me is the way in which filler behaves on ultrasound. If you look at injecting under ultrasound, often the filler doesn't end up where you want it to go. If you're going to inject 20 mils into a patient in a single setting, it's not going to be that way in 6 months' time. It's also important that we sequence the treatment over multiple sessions, and your patients have no additional benefit to having one single big treatment as part of what we're calling here the volume era, compared to sequencing it over 2 or 3 sessions. And so patient expectations have changed. We have this thing going along, which is called filler fatigue, where the industry is seeing a dip in filler sales, and we're seeing an increase in regenerative treatments. And I want to tell you my personal view on what's going to happen with fillers over the next 5, 10, 15 years. Okay. So I think we have badly mistreated injectables. And I think that uh, we have used volumizing gels as a tool to treat every kind of presentation. And we haven't been injecting in a way that is based on fundamental first principles, a scientific approach. And we've been led by consumer trends or pharmaceutical interests rather than uh, getting what's best for the patient. And so injectables had a bad reputation with the patients 5 years ago, and then recently it's had a little bit of a bad reputation with clinicians. The reality, though, is that fillers are essential as part of our mix in medical aesthetics. And there is nothing that's going to replace volumizing gels for structured volumetric improvements. They also have this fantastic and immediate response, which is something that no other treatment really can have. And so, what I believe is that injections are going to come back, volumizing injections are going to come back, and we're not going to call it volumizing, we're going to call it structuring or shaping. And when we do come back to this, which I think is starting in 2025, it's going to be in a much more intelligent and evidence-based way. And I think it will be less prone to the influence of big pharmaceutical companies. And I think it's going to be more about the upskilling and the better understanding of from healthcare professionals. And so, what I want to touch on today is some of the core principles that I think are driving this change and how we can start to think more intelligently about injectable fillers or volumizers. I appreciate that we've got some very experienced injectors on the webinar this evening, so really do appreciate your time. And you may have some insights I don't have, and I'm very happy to have a discussion with you about this. So, the first thing I'm going to say is obviously tonight we are here with Prolenium, and the reason I work with Prolenium is because I think they do have a very modern, cutting edge range of gels. And the reason I say that is the primary benefit that I see in my patients is the fact that when we inject our patients, we do not have the ongoing risk of inflammation and we do not have the swell factor. And I saw a fantastic chart comparing the Revanesse range to the other major filler ranges, comparing it in terms of the hydrophilic effect of the gels. And the Revanesse gels have the lowest swell factor. And in fact, Revanesse Revise here, because I'm highlighting it, has the lowest swell factor of any of them based on that study. And the reason for that is because these gels are pre-hydrated, and that means that when they're then injected into the tissues, they don't have the same swell factor with the absorption of water. Okay, and so that's a very simple reason for why I would be happy to do this webinar with Prolenium this evening, and it very much is in keeping with the theme of strategic precision for injectables. So let me share with you three concepts. These are going to form the basis of our webinar and our discussion this evening. So the first thing I'm going to talk about is something called the surface volume coefficient. I'm going to talk about an anatomical structure called the transverse facial septum. This is talking specifically about the midface. Okay. The second thing I'm going to talk about is how filler moves in the acute phase when we're injecting and how we can minimize displacement of filler. The third thing I'm going to talk about is the line of ligaments and how that tells us how to sequence our injections and also how it means we can use less volume to get the same result. So let's get started with the first one. So paper came out 6 years ago, the surface volume coefficient of the superficial and deep facial fat compartments. So this was a study that looked at the way in which we inject some of the deeper compartments of the face and comparing how much volume goes down into those deep structures compared to how much we actually see on the surface of the skin. And this is really this is really important because if we're going to inject 0.5 ml of a gel, then there are some areas of the face where the patient may not even see a benefit. And so why would we focus our gels on parts of the face where we're just going to be adding more and more hyaluronic acid, but not actually achieving a result? So this relationship between the volume we inject and what we see on the surface of the skin is called the surface volume coefficient. And I'm showing you some of our 3D visuals here because this injection here, this little fat target here behind the levator labii superioris muscle, is called the deep medial cheek fat. That has been shown to have a low surface volume coefficient, whereas this target here, which is the pre-periosteal fat and more anteriorly the suborbicularis oculi fat, the SUF, this has a high surface volume coefficient. And that means that if we're going to inject zero point 0.3 mils of filler, the patient is going to see a more visible impact if we inject here compared to here. Even if they really need it here, if we had a small amount of filler, the apex of the cheek in this case would be a better target to use that gel. And so the SVC gives you a tool for how to plan your injections if we're now in a world where we don't want to use 15, 20 syringes of filler. Your patient wants to have 4 to 5 mils of filler. Well, then let's think about which are the most important targets to treat the patients in terms of the facial aging process, but also where we're going to get the most impact. So this is just a little chart from that paper, which shows if you look in green here, this is the suborbicularis oculi fat. You can see on the x-axis the injected volume, so going up to 1 mil, and then on the y-axis the measured volume, so how much was changed in the surface of the skin. And you can see with the SUF, it's almost 1 to 1, okay? And so that's a highly efficient use of your gel. Whereas in yellow down here, you inject a syringe of filler, but you don't get even half a syringe of surface change to the patient's skin. So hopefully this can start to change the way in which you're thinking when you're considering which target zones of the face to prioritize if your patients are now moving to a more low budget, low volume, more precise approach. But please don't misunderstand me. If your patients do need these anatomical targets that have deflated, then it's still something we need to inject. Okay, I'm not saying ignore the areas. I'm not saying that. I'm saying that if we're starting to be more strategic about the volumes we're using, then there are certain areas which will have more impact. Okay, so that for me is a central idea of precision injecting. Not all zones are the same. One of the risks of adding too much volume, as we've mentioned before, is this risk of migration, product moving in the wrong places, okay? The other is that if you add every single incremental amount of volume increases the risk of a complication, whether it's a vascular complication or whether it's a delayed onset nodule. And so, as in more of an ethical principle that we have, is that we have to use the minimal amount of volume to get the best results, or to get the result the patient is looking for. And so there is no benefit to adding additional volume where you don't want it. And one of the worst things that we can do for our patients is this risk of overfilling and this idea of pillow face. And this is something I really want to share with you. So if you look on this diagram here, you have here your zygomaticus minor. This is your and that's inserting into the modiolus, and here you have your zygomaticus major, which is so the minor is inserting into the upper lip and the modiolus, and the major is inserting into the modiolus. Okay, the thing about this muscle, the zygomaticus major, is that it's been shown that it's not just a muscle. It's also got a connection all the way down to bone, right? And that creates something called the transverse facial septum. And I'm just going to pause here because I want you to see this on my face, okay? So if you've got this septum that's going down from the prominence of the zygomatic bone to the corner of the mouth, what happens is when you smile, this this muscle is contracting, but it's also then bunching and pushing forwards all of this anterior cheek volume. And so the reason why this part of the face is so sensitive to overfilling is because if you put volume in into the superficial aspects above the lip elevator muscles in this part of the face, then when you smile, some patients' cheeks are going to look very anterior projected because the muscle and the associated septum is pushing everything forwards. And so, what this tells me is that um, we have this division that divides the midface from the lateral midface and the medial midface. This is called the line of ligaments, and it's my third principle that I'm going to talk to you about today. But what it tells me is that when we're injecting this medial aspect of the midface, we have to be deep, first of all. And if we are going to inject subcutaneous, which I rarely recommend, then we have to make sure we're using very small volumes. And so this is the main reason why the medial midface is easily overfilled. And so we avoid injecting into those layers above the lip elevator and above the orbicularis oculi muscle. And that is going to help us to create these results that we're going to get. I think we're going to move away from having this puffy mid-face appearance because of anatomical insights like this one, okay? The way in which the face moves and the structures that divide the mobile and the passive mid-face. So I'm going to come on to that line of ligaments as my third point, but I'm going to move on to my second main point, which is around uh, precision injecting. And what happens, unfortunately, when we inject our gels, if you look on ultrasound, if you look at some of the published studies talking about displacement of the gels, is that when the needle touches down onto bone and you inject, for example, you're treating along the cheekbone, okay? The gel itself will follow the path of least resistance and it will flow back up the channel that you have created with a needle or a cannula. And the bigger the needle and the bigger the cannula, the more likely that gel is to flow into the superficial tissues. And so, one of the key principles we have about being precise with our filler is that there are various factors we can change to increase the likelihood that the gel will stay down on bone. Okay, so let me show you something that's, I think, a really important insight, okay? I've shown you this before. This is a needle touching down on the projected apex of the cheek. This is what you would do to create that beautiful cheek apex, the light reflex. Most injectors will approach it like this. And what will happen is the gel will sit in here. This is the pre-periosteal fat. This little blue area is your prezygomatic space. And then you have a little fascial compartment that divides the prezygomatic space from the fat pad underneath the orbicularis oculi. and that is the SOOF. Okay, so you pre-periosteal fat, then you pre-zygomatic space, then we have a deeper facial septum, and then you have the SOOF, and then you have the orbicularis oculi muscle. What happens when you inject down on bone here is the gel will flow upwards and it will usually end in the SOOF. But if we're not careful, it will move into the subcutaneous fat in the anterior aspect of the cheek. And this is what we don't want because this is where patients can be prone to malar edema. And this is where we have that risk I explained where if the gel is sitting here, the transverse facial septum will push everything anteriorly and we have this pillow face appearance. So there is something that we are starting to do and we're starting to develop some evidence on, which is an approach that actually helps you to retain the gel in the deeper fat plane or the pre-periosteal fat. And to illustrate that, I'm going to show you a video. So let's take a look at this. I want to talk through the anatomical compartments that our needle moves through when we want to try and create projection here, because it's really important that we're specific about where we want the filler to end up. So in this part of the midface, we have a complex set of layers and anatomy. Let's go through them in order. So first of all, we have our skin, then we have our subcutaneous fat. Beneath that, we have our muscle, which is our orbicularis oculi muscle. We, of course, need to go through the muscle, and then we're into a deep fat pad directly beneath the muscle, which is the suborbicularis oculi fat. So if I draw on here the perimeter of our orbicularis oculi muscle, then we have directly underneath the muscle, we have the medial SOOF and we have the lateral SOOF. This apex is at the intersection between those two fat pads, but our injection is going down onto bone. There is some complex anatomy even beneath the SOOF that I've drawn on here. So what lies underneath the SOOF? Well, we have a fascial plane. That fascial plane is the mid-facial extension of one of the fascias in the temple. It's actually the superficial lamina of the deep temporal fascia that extends across the midface. So when our needle goes through the SOOF, it then goes through this fascial plane and into an even deeper fat pad called the pre-periosteal fat. And so actually, when we're treating down onto bone here, our filler ideally is sitting within the pre-periosteal fat of the midface. Having said that, the filler often tracks backwards through the canal that our needle makes. And so quite often the filler will move through the pre-periosteal fat, through the fascia into the SOOF, and if we're not careful, into the subcutaneous fat, which is what we want to avoid. So I'm going to show you a technique today for how to inject onto an apex of a cheek to ensure the maximal probability that the filler will stay where we intend it to stay, which is right down on top of the bone. So there are various factors that determine exactly where the filler is placed after injection. One is the angle of the injection. A more perpendicular angle is more likely to allow the filler to track towards the surface near the skin, whereas a more 45-degree angle is more likely to retain the filler near the bone. Secondly, the bevel of the needle. If the bevel of the needle is facing down towards bone, we're more likely to keep the filler underneath that fascial plane near the bone. Next is the G prime of the filler. The stiffer the product, the more likely it is to stay in place. And finally, your injection speed. If you inject slowly, it's more likely to stay in place. And so combining all of these together, here is how we can treat the apex of the cheek, creating deep, structured volume with minimal chance that the filler ends up in the wrong depth. So we're going to go for 0.2 mils per side. I've got the bevel of the needle facing forwards initially, and a little scratch. We're through the second fascia because I felt a click. Okay, I'm now going to turn so that the bevel of the needle is facing down towards bone, and I'm going to aspirate. And then I'm going to slowly inject. And then slowly remove. Now let's just take a look at that one injection and see how it looks. Sit forwards for us. So I hope you can appreciate here how much it can improve the shape of the face, and in particular the OG curve on the patient's right side. Okay, guys, so let me put my video back on for a sec. Okay, so what I'm what I'm trying to show in that video are um five key um parameters that change where the gel goes when you inject. Okay, because I showed you this, right? And I showed you that the filler moves away. It wants to follow the path of least resistance. So what can we do to maximize the chance that a filler stays in place? Well, number one, if we inject at a 45-degree angle, then the gel has a chance to stay captured by that deeper fascial plane of the midface. Okay, I described that. It's a very anatomical, in a very anatomical way. It's the superficial lamina of the deep temporal fascia that's extending across the midface. It's one of the very deep layers of the temple, actually, that's moving and creating this deep compartment, which is the ceiling of your prezygomatic space. That can then capture a gel if you're injecting at a 45-degree angle better than a 90-degree angle. So that's one thing you can do. The second thing is the bevel of your needle. If you're facing down towards bone, you will inject the gel, and again on ultrasound studies, you can see that that encourages the gel to reside in that deeper compartment. The third one is really, really important, okay? The slower you inject, the less chance the gel has of flowing backwards through this channel. And that's because it's a lower pressure injection. And so if you inject slowly, your patient will not have filler that moves. And that's something that I teach all kind of injectors as they're starting to inject. When you're injecting the plunger, you have to be slow. There's other reasons for that. It reduces risk in other ways, but it's also about the positioning of the gel. Next is the actual gel that you're going to choose. In this case, using Reviness shape. Okay, higher G prime gels, stiffer gels are more likely to stay in those deeper compartments. If I was injecting something like Reviness Kiss, again, a more fluid gel is more likely to track back up through the needle or the cannula. And then finally, if we're using cannulas, it's just worth mentioning that even though we use larger cannulas because they help to stay within planes better, they actually enhance the ability for gels to move. So a smaller cannula will help with positioning, but a bigger cannula will actually reduce the risk of you being in the wrong plane. So there's a little bit of a compromise there when you're thinking about the cannula. So this is all quite new information, and it's all, I think, a little bit challenging for new injectors because there's enough to worry about when you're injecting beyond now having to think about angles and position of the bevel. But this is what I mean when I say that uh, we're going to start injecting fillers again as an industry, and I think we're going to be doing it in a much more strategic and structured way because of what we're starting to learn about the ways in which these gels behave and these compartments that we can actually inject into. What I've mentioned there is a little bit complex. And so if you have any questions on that, please don't hesitate to ask me at the end or drop me a message in the chat. I'll just answer this one briefly now. Uh, do you maintain contact with the bone when injecting? Um, or do you retract the needle a bit back before injecting? See, I just touched down on bone just to get my position, and then back just a millimeter. I think that's probably gives the gel a chance to actually come out of the needle. Um, Shalini, especially if you're positioning the bevel downwards towards bone. And then Kinza, would you use contour on cheeks? Yes, I would in patients with thin skin. So shape is good, but you can also use contour. If your patient has thin skin, then you don't want to use something as stiff because you can actually see the gel under the skin. So based on skin thickness and subcutaneous fat, we can use contour or shape for the cheek like that. Okay, guys, and the third final point I want to talk about is the line of ligaments. Okay, this is a ligament line that's moving from the up here in the temporal adhesion. Okay, it's moving into the lateral aspect of the orbicularis retaining ligament. That's the lateral orbital thickening. Then we have the origin of the zygomatic cutaneous ligament all the way down here to the mandibular ligament. This line of ligaments divides the face, as I've said, into the medial and the lateral midface. And that's how we talk about um, the midface in two different zones, medial and lateral. The medial midface is mobile, and I just want you to do this, right? If you can see my face for a second, we're going to come back to my face, okay? If you put your finger in the medial midface and then smile, okay, you'll notice that the lip elevators lift your finger. Whereas if you put your finger on your cheekbone back here and smile, it doesn't move. Okay, and the reason for that is because we don't we have the lip elevators all exist medial to this line. Okay, so we're talking about the levator labii superioris, the zygomaticus minor, the zygomaticus major. They all exist medial to this line of ligaments. So this is really important. The lateral aspect of the line of ligaments is a passive structure, and when it ages, the tissues can just gently sag downwards. That's why we form jowls. The layers are concentric layers, like an onion. Okay, so you've got skin, then you've got subcutaneous fat, and then you've got the SMAS plane. Whereas these structures, these lip elevator structures, they move through the layers. So they go from bone, for example, the zygomatic bone or the infraorbital rim, and they insert into skin, which is the corner of the mouth. And so you have muscles that move through the different layers. And that creates a very different support structure for the medial aspect of the midface. What we've shown in the literature is if you inject first in the lateral midface, we then need, and that helps to reposition the tissues. It also helps to create tension across the midface. Then we actually need less volume to then treat the medial midface. And so it tells us about sequencing. It means that if your patients are concerned about volume loss in the medial midface or nasolabial folds, then we're first going to start to treat laterally, and that's quite intuitive for most injectors. But I also want to explain that there are some scientific and anatomical reasons for how we can divide the midface and think about injecting in sequence. And that's because of the arrangement of the line of ligaments and the muscles that traverse through the layers either side of those ligaments. So, what injections can we do lateral? This is part of a framework that we are introducing with Prolenium called the GEM or the Global Evidence Matrix. And we've done a full review of every type of possible injection you can do with a needle or a cannula and started to map out injectables in quite a systematic way. And so there's only three things we can do, okay? Lateral in the midface. One is the zygomatic arch with a needle. Number two is zygomatic arch with a cannula subcutaneous. And number three is preauricular. And so this is what it looks like in every zone of the face. We talk about the stage of injectors. This is a totally acceptable injection for beginner injectors. 27 gauge needle, aspiration, treating down on bone, high G prime product like shape. Fantastic. Okay. That's what it would look like. We're doing that injection to try and create that lateral traction. So then we actually need less volume in the medial midface, which again is part of our strategy to reduce overfilling and be more precise with the volumes we're injecting. Second, we can treat the preauricular region with a cannula. Again, mentioning what I said before around using a larger cannula, because when we're injecting in this plane, we have to be very careful not to damage the underlying parotid gland here. And so if you're using a thicker cannula, you're safer because you're less likely to dive into the deeper planes of the midface here and damage underlying structures, in this case, the parotid gland. And the third is again using a cannula just under the skin in the subcutaneous plane to create this lateral definition along the cheekbone. So that's just a little teaser for how we would start to approach the face, and a little teaser of the GEM protocols that we're starting to roll out with Prolenium, which is a big part of what we're involved in at the moment. Guys, I'm going to finish up with a couple of case studies, and this is hopefully going to help to illustrate some of the principles that I've been talking about, and then we can have a few questions. Okay, so first of all, this patient came to see us in clinic. We've filmed this. I think it was a 5-part series that we're going to publish soon, and she has some of the classical signs of overfilling. So you can see, hopefully you can agree with me, she looks like she's overfilled in the midface. She's certainly had too much volume in the lips, which has started to migrate beyond the lip border. She also had under eyes that were overfilled as well. And so this is quite common in patients who have had, 10 years of injectables, but done in a fairly haphazard way, where patients are just they're getting volume loss treated, but they're not thinking about where the gel is going. So we looked at her on an ultrasound scan, and this is something we're seeing more and more in clinic, which is that these black nodules, they're just lumps of hyaluronic acid gel that start to form these nodules over time. This was actually found within layer 3. So this is gel that's stuck in the SMAS plane and also in the subcutaneous fat. This is not where you want your gel to be in this part of the face, right? This is exactly what I talked about, where if the patient smiles, all of that gel is being pushed forward by the transverse facial septum, and she's getting these over projected cheeks. So we dissolved all that gel, and you can see here the amount of volume loss that was naturally present in her. So she is a very good candidate for hyaluronic acid gels. And then treating her in the kind of ways that I've described on this webinar, we can then get a beautiful, harmonious, much more natural result. And this is kind of quite a dramatic before and after for her, just using the Reviness gels and no skin tightening in this patient. Okay, so a really nice case study to show you. The second one is a younger patient, and this is someone, imagine, that comes to see you. She's actually in her late 30s, and she's concerned about some of the signs of aging, particularly under the eyes, around the temples. She also wants a little bit in her lips, and uh, this is the kind of patient I think we probably mistreated 5, 10 years ago, and we tried to sell her, 6 mils of filler. We were saying, okay, we'll do this, we'll do that, and we injected in ways that were not particularly anatomical, and I think we mistreated them. And so I want to show you, hopefully, what you'd agree is quite an elegant treatment for her. First of all, looking on the 45-degree angle, she had filler in the forehead. Okay, so I really like this treatment, and it's totally reasonable in this case. You can see up here the little bit of hollowing in the forehead. So this is using Revanesse in the forehead. Okay, and then we treated her mid-face, treated the apex. She didn't need anything in the lateral aspect of the zygoma, already beautifully defined. Certainly no volume in the medial midface, absolutely no indication for that. Tear trough filler, that's beautiful. That's Revanesse Revise. And then finishing it off with a little bit of ultra in the jawline and then in the lips. And so you can see from the side here, hopefully you can see the the forehead improvement. Okay, I really, really like this. Her nose has been treated with shape as well. I forgot to mention as well, just a little bit in the nose with shape to add a touch of definition and to create a straighter profile. Um, and so this is hopefully how we're going to start to see more injections in the future. The key points being around using less gels in the right compartments to get more precise and specific, accurate results. So just to summarize, three major concepts that I've talked about this webinar. One is um, the displacement of gels when you inject, and hopefully giving you some new ways to think about how you're injecting and where the gel will actually end up. The other concept at the beginning was the surface volume coefficient and understanding that not all zones of the face have the same results. And then finally talking a little bit about the line of ligaments and some of the biomechanics of the midface. So I hope that's been useful, guys, and really enjoyed running through that with you. And we've just got a few minutes now. If you want to ask me any questions in the chat, I'm very happy to take any questions.
Thank you so much, Tristan, for this really, really interesting presentation. Thank you, everyone, for attending, and we can now move on to the questions. Yes, don't hesitate to ask your questions in the chat or in the Q&R. We already have some questions. We can start with them. I know you've already answered it, but the question was asked again. Maybe it wasn't clear or something. Maybe we can answer again the question of, would you use contour in the cheeks?
Yeah, and I think I use contour or shape in the cheeks based on the thickness of the skin and the subcutaneous fat. So aging patients, very thin skin, contour. Younger patients, thicker skin, more fats, definitely okay to use shape.
Thank you. Would you say HA is more preferable than a biostimulator like Radius or Sculptra?
So they have different, we need to use both, right? So the 100% we need to use biostimulators and 100% we need to use hyaluronic acid gels. And biostimulators are important, especially if you mention what I said about the lateral midface. We have this passive sagging motion. So we have the opportunity to reposition the skin in the lateral midface using biostimulators. And so that's why, for me, biostimulators are always going to be very good at treating this lateral aspect of the midface, moving into even the temple. And so we need to try and create this lateral tension and this repositioning. But what biostimulators can't do is actually address, for example, significant deep maxillary recession, piriform fossa, the deep medial cheek fat, the SOOF. We wouldn't want to use a biostimulator in the SOOF. And then, of course, some of the more refined volumizing treatments like noses and lips, they have different places. And so it's all part of the toolbox.
You've mentioned the gem in your presentation. Can you present us a little bit about the gem and how is it linked with Revanesse?
Sure. Yeah, let me show you. Uh, 1 second. Okay. So let me show you something. So we did a global consensus study on which parts of the face were considered high difficulty and which parts of the face were considered high risk. And based on this, we started to map out a matrix for injecting the entire face. And this was based on a few hundred survey responses on which zones are suitable for beginners, which zones are suitable for experts. And so for every single zone of the face, like I've shown you, we've got a little matrix to share. But this is what it looks like in full. So this is us trying to map every type of filler injection, telling you which kind of cannula, which kind of needle, and the anatomical targets. And this is something that we're rolling out to Prolenium customers, which is a uh, iPhone application and a desktop application where you have this as a clinic reference guide. So if you're injecting any part of the face, you can choose which product you have in your cupboard. So here we're choosing Reviness Shape and Contour and Outline. Okay, and it tells you which treatments are possible. We can choose which zone we're injecting. And then based on this, we have the information, so you can then understand um, how to do the injection and also a description of the injection, the medical risks and the aesthetic risks. All of this is based on a literature review that we've conducted over the last 2 years, so we can hopefully really help injectors have this guideline for how to practice in this new modern way that I'm describing. And it's going to be slowly rolled out through various train the trainer programs as we go through the year.
Great, it looks amazing. Good job, Tristan. I'm sure everyone is excited to try it out. We have new questions over here. Which product do you suggest for lateral subcutaneous with 22-day cannula?
Which product do you suggest for lateral subcutaneous with a 22 gauge cannula? Um, it's similar to our mid-face gels. So we're using Shape, we're using Contour to treat this part of the preauricular region. Yeah, I'd recommend Shape or Contour.
Okay. And can you specify the targeted area on a shallower layer and not the bone?
How can you specify the targeted area on a shallower layer? I'm not sure I fully understand that question, unfortunately.
Okay, so whoever asks the question, don't hesitate to maybe specify in the chat so that we can answer properly, and we'll ask other questions in the meanwhile. Do you always use the bolus technique and not the linear for lateral or medial face?
So lateral and medial midface, we use both. So with a needle, we were always going to be injecting with a bolus, but with a cannula, we can fan. So for example, that apex I showed you here, we also have a video showing you how you can do that and accessing that deep preperiosteal fat using a cannula, in which case you're fanning into the apex of the cheek. So I have a beautiful video I can show you for that one, Dimitra.
Okay.
Um, shall I just answer these,
Yeah,
Hannah?
go ahead, Tristan.
Um, So Elizabeth, where can we find that map? That map is with Prolenium. So that's going to be available for you slowly over the next few weeks and months. It's also available to Harley Academy customers. So if you want to get in touch with us at Harley Academy, we can show you the gem product, which is really which I think is super exciting. Okay, I'm going to take the one at the top. Would you be able to provide the research you cited? Yes, absolutely. So there's a paper at the start with from Kotafana and Dr. Konstantin Frank talking about the surface volume coefficient. I can show you a paper about the transverse facial septum, and then there's also another paper about the line of ligaments and the volume needed either side of that. So yeah, there's definitely 3 papers we can share with you for that, Lynette, no problem. Would you recommend Sculpt for the lateral cheek? Yes, Sculpt. Oh, Sculpt, I can't answer. I don't know about Sculpt personally. So I'm gonna, that's a product I haven't actually had my hands on, Shabnam, so you're gonna have to forgive me on that one. Um, Hannah, this recording, is it available?
Yes, so the recording of the webinar will be available from tomorrow, and each and every one of the people that subscribe to the webinar will receive it by email tomorrow.
Cool. Okay, I'm going to answer this. I understand this question now. Okay, so when we explained about injecting and the angle of the 45-degree angle, if you inject other layers of the face, how can you avoid the migration of material? So what I'm describing in that technique is really something specifically for when you're going with a needle down onto bone like this. But the same principles apply for, let's say you're injecting um, the chin, okay, and you're trying to inject in the subcutaneous plane with a cannula, right? Um, the same principles. If we're injecting and we're using a high G prime gel, something stiff, if we're injecting and we're using a smaller cannula, even though that's difficult, okay, and if we're injecting with a low pressure, then the gel is more likely to stay where we're injecting. If you injected something very soft, very fast, and you created a big track with your cannula or your needle, it's going to move. It's going to move the moment you inject it. And so some of those principles are universal for keeping filler where you want it to stay.
I think there's a last question about which product are you using in the temporal area with a cannula?
So in the temple, we have three different techniques. Okay. So with a cannula, we have two techniques. We can inject in the subcutaneous plane, and that one is um, uh, with a cannula, with a 22 gauge cannula from underneath. Here, we're going to use something like Contour or Ultra. I wouldn't recommend anything stiffer because we're in the subcutaneous plane. Okay, so Contour and Ultra. If you're in the interfascial plane, coming from the forehead down into the temple, then I think you can use Contour. You can use Ultra or Contour or Shape because you're in a deeper depth. And I've had very good results with both Contour and Shape with a cannula in the interfascial plane in the temple. All right, guys, I'm gonna have to wrap this up because I'm starting to lose my voice and I have another injection, another webinar to do.
All
Um,
right, thank you. Thank you so much, Tristan. It was really amazing. Thank you, everyone, for attending and for all of the questions. Again, the webinar was recorded and it will be available from tomorrow. You will receive it by email. You will receive the replay by email. Again, thank you so much, Dr. Mehta, and we will see you all on the next webinar.
all right.
Thank you.
Lots more to say, guys. So hopefully we will speak again soon. So thank you, everyone. We'll see you again.
Goodbye.
Night. Bye.